So welcome to the Great Debates and Updates in Temperature Management, the virtual symposium. We hope you enjoy today's virtual event where we have an expert panel discussing 3 topics. The first topic will be the Practice Changing Updates panel, which the content is ERA Society Guidelines Recommendations for Prevention of Perioperative Hypothermia. The second topic will discuss the impact of inadvertent perioperative hypothermia, causes and consequences. We will wrap up the day with our third topic on great debates and updates in temperature monitoring. So thank you for joining us for this important educational event, and we hope you will find it beneficial for your own practice. It will start us off with an overview on ERAs, how we develop the guidelines, and how the adoption is, and how we can influence the outcome by implementing elements, and especially regarding temperature management. So let's start. So first of all, I would like to introduce you to the faculty. We have 3 speakers, but first of all, I would like to introduce my co-speakers. Kerry Cole, she is a chief nurse anesthetist from the US. Actually, she is an assistant clinical professor at Keck School of Medicine of UCS, Los Angeles in California. And furthermore, we are very pleased to have Kathleen Ferguson. She is an ERAS coordinator in St. Martin's Hospital in Nova Scotia. And I'm Hans de Boer, an anesthesiologist and pain specialist. And I'm also the chairman of the ERA Society. And my basis is the Martini General Hospital in Groningen in the Netherlands in Europe. So please also take a look at our disclosures of the speakers. And then we will continue. So I give you some program information. So this program is provided by HMP Education and AMP's global company, and supported by an educational grant from 3M Healthcare, Medical Solutions and Divisions. So I would also like to thank the organizing committee and the program assistants for assisting us in this webcast. So we have some learning objectives for you. So I will discuss them very shortly. So explain the importance of temperature management during all phases of the perioperative journey, and describe warming protocols implemented to support an ERAS bundle. Furthermore, to discuss key metrics used to evaluate warming protocols. And furthermore, outline the strategies to collaborate with industry partners to have a successful implementation. We also will discuss the importance of a multidisciplinary team approach when implementing ERAS bundle patient warming protocol, and discuss the role of the patient engagement in successful implementation of ERAS guidelines. So I'd like now to start with my part of the presentation, and that's on the ERA Society Guidelines, Prevention of Perioperative Hypothermia. And I will give you an overview how the ERA Society Guidelines and the ERAS implementation will have its effect on the patient outcome. So this is the agenda for my talk. It's the value of innovation in healthcare. I will give you the definitions of ERAS and what is the heart of ERAS, and of course the patient outcome. And I will give you a very brief overview of how we develop our guidelines and draw some conclusions. So the value of innovation in healthcare. So what is innovation in healthcare? Innovations are not limited to new drugs or devices. It's about organization, it's about patients, but it's also about physician, nursing, and more importantly, also the support of information technology. And that makes that some of the most important healthcare innovations are in the way the delivery of care is organized. And ERAS actually is a good example of a good working innovation in healthcare. I will explain that a little bit later. So we also have challenges in healthcare, and we have some ERAS goals. So we have to realize in the global healthcare challenges that 5% of the population is operated in the Western world. And about 320 million operations are performed annually, of which 25% will face complications. And we also have to realize that there is a huge variation in care. And when we like to change, we also have to know that it takes almost 15 years or more to change practice. But when having the ERAS goals in mind and results, we think of a shorter hospital stay, reduction in complications up to 30 to 50%, but also saving costs. And ERAS is associated with improved survival. And when we review the literature, we know today that ERAS has achieved a significant benefit for patients and healthcare systems. However, improvements are still needed, particularly on areas in patient optimization and systematic implementation. And during this global crisis, after the pandemic, the ERAS method of delivering care is required to take surgery and anesthesia to the next level and bring improvements to outcomes of both patients and health systems. So let's continue to the definitions of ERAS. Well, this is a definition defined by the ERAS Society. And ERAS is actually the immediate challenge to improving the quality of surgical care is not discovering new knowledge, but rather how to integrate what we already know into practice. And these are the cornerstones of ERAS. It's all about the evidence-based perioperative care. It is a multidisciplinary and multi-professional approach, and it's teamwork. And very important for the results, it's a continuous interactive audit and reporting. And by that, you can have a data-driven change in healthcare. But more importantly, everyone involved should be ready to make the change. And ERAS is a multidisciplinary team approach. It's about the surgeon, the anesthesiologist. It's about the AGU specialist, the intensivist, but also about nursing on the ward, anesthesia nurses, physiotherapists, dietitians, but also the management. I will explain that a little bit later regarding when you are looking more closely to costs. It's teamwork. It is training, implementing, planning, but also auditing of your outcomes, reporting, and of course, research is important to have more evidence in our guidelines. So when we focus on the patients by following the patient's journey, we have an integrated ERAS protocol implemented from pre-admission to 30 days post-operatively. And of course, it's important to have an interactive team audit of the outcomes and compliance. So the heart of ERAS and patient outcomes. The heart of ERAS is modulation of surgical stress. And actually, the cornerstones are individualized fluid therapy, effective analgesia, but also more elements like prevention of hypothermia. So by modulation of this stress response, you will decrease complications, have optimal healing, and a decreased length of stay. And we have to realize that surgical stress leads to a prolonged recovery after surgery, an increased length of stay, increased readmissions, but also increased complications like PONV, pain, wound infections, ileus, and anastomotic leakages. And surgical stress leads to an increased morbidity and mortality. And it is also extremely expensive. When we review the meta-analysis of Greco, already from 2014, in pooled data, they show that you can reduce complications by 40% when implementing a full ERAS bundle. And also we have to realize that reductions in complications are actually the key of the ERAS philosophy. And complications not only affect short-term morbidity and mortality, but also impacts long-term outcomes. And also we have to know that complications within 30 days are more important than both preoperative risk and intraoperative factors in determining survival after major surgery. And complications reduce survival by almost 70%, from 18.4 years to 5.6 years. So complications and prevention of this is really important. When we look further at the Greco paper, we show that the ERAS implementation shortens the length of stay by 2.3 days. So that's a major reduction in length of stay. So what you can see when you review all our ERAS guidelines, what do they preach? They preach a multi-model approach, reduce stress and support function. And as you can see, we have many ERA's guidelines on several different surgeries. And you can download them for free at our website. So how do we develop our guidelines? This is an important paper. It is published already in 2020. It's about recommendations from the ERA Society for standards for the development of enhanced recovery after surgery guidelines. And this paper is the basis of the development of every ERA Society guideline, because we like to review the literature and we do an assessment of the evidence through the GRADE method, where we have the quality of evidence from high, moderate, low to very low. And therefore, based on this, we can do recommendations. And the GRADE assessment can also give us an advice of the strength of recommendations from strong to weak. And actually, this is also applying for the latest update of the colorectal ERA Society guidelines, which was published first in 2018 and in paper in 2019, where you can also see that, for instance, normothermia is a very important key element of the ERA's bundle. And the quality of evidence, maintenance of normothermia is high. There's so many papers which shows evidence. Monitoring of temperature, which also be addressed later on, is high. But also the recommendation grade is strong. So preventing hypothermia throughout the procedure is evidence-based medicine with high evidence and a very strong recommendation. So, and there's also debates on ERAs versus non-ERAs. So everyone knows, well, my hospital is doing ERAs, but what is real ERAs versus non-ERAs? And this was nicely addressed by the POWER study from Spain, published in JAMA Surgery in 2019. They compared two hospital groups within the Spanish region, where they show the association between the use of an enhanced recovery after surgery protocol and post-operative complications in colorectal surgery. And the POWER study shows that having a protocol is not enough to improve outcomes, but an increase in adherence to ERAS items is associated with a decrease in post-operative complications. And therefore, continuous auditing of adherence to ERAS and post-operative outcomes is essential. And that makes the distinction between the real ERAS hospitals and the non-ERAS hospitals. So we talked about complications, length of stay, but there's another association which actually is evidence-based, and that is ERAS cost savings. And when you see this table from the last review from our society in JAMA Surgery from 2021, you can see that the cost savings associated with ERAS programs. And you can see the very different surgical programs. And you can also see the savings per patient, which is very impressive. And nowadays, in restricted resources from hospital management, this is a very important issue to implement ERAS as soon as possible. And the return to investment brings $1 brings up to $7.3, which means it's really cost saving, but also you have better care. So in conclusion, ERAS is a multidisciplinary team approach. It's about implementation of evidence-based medicine, what I showed with the prevention of hypothermia perioperative. It's reduction of surgical stress response, reduction in complications and length of stay, and a continuous audit of the outcomes. So when implementing ERAS, you have better care for less costs. So where is the ERAS today? You see a map where implementation has occurred in more than 250 units in more than 25 countries. And we have to see that ERAS is booming after the pandemic, because our healthcare can be very much better, but for lower costs. And that's really a good opportunity to implement ERAS also in your hospital. I would like to thank you for your attention, and I will continue to introduce my colleague, Kerry Cole, from Los Angeles, and she will talk about the practice in changing update panel and ERA Society guidelines recommendations for prevention of perioperative hypothermia. Please, Kerry, the floor is yours.
Thank you, Dr. DeBoer. Again, my name is Kerry Cole, and I'm the Chief Nurse Anesthetist here at the Los Angeles County USC Medical Center. Also just an ERAS enthusiast, looking forward to sharing with you our implementation here at this medical center. So we use many guidelines to help implement our efforts at preventing hypothermia in the operating room, including the NICE guidelines, which were really provided a simple, straightforward, meaningful recommendations for things such as, some of my areas of favorite were the patient education portion, the preoperative patient education portion that described, letting the patients know what to expect as far as being in a cold operating room environment, to dress warm. That implementation would take place to keep them from getting cold. It also provided nice guidelines for provider and staff education. So, for example, making sure that all staff knew how to use temperature monitoring modalities as well as warming modalities. And while that seems like it makes common sense, it is nice to review that. That's a big portion of what I implemented in this institution, was just education and re-education of our patients and our providers. Looking forward to looking at the ERAS Society guidelines. Again, just another slew of supporting documentation and why we should prevent hypothermia, perioperative hypothermia. There seemingly wasn't a subspecialty in surgery that didn't advocate for this. So preventing perioperative hypothermia was a common goal across all of our surgical specialties at this medical center. I know we will talk about this a little bit later as well, but just in rolling out efforts to prevent hypothermia, people need to know why we're doing that. So, for example, with hypothermia, you run the risk of an increased rate of wound infection. And of course, with that comes patient dissatisfaction, morbidity, mortality, readmissions, additional costs. In addition, a hypothermia intraoperatively or perioperatively can cause coagulopathies. And as a nurse anesthetist, I can hear that happening when, say, for example, the Yankar suction starts to increase a little bit, and we start to notice some oozing on the surgical field. I've also noticed that hypothermia does affect the drug metabolism. So, for example, we can see delayed emergence from anesthesia, as well as just longer metabolism required for things like muscle relaxants. Myocardial ischemia, again, disturbances, lots of PACs, PVCs. Quite honestly, being cold does require additional oxygen consumption, so they're running the risk of cardiac ischemia due to oxygen demand. And then patient discomfort postoperatively with shivering and thermal discomfort. All of these we want to avoid. There are multiple modalities for warming patients. Not all of them are made equal. We really rely on almost all of these, but we mostly rely on forced air warming. That's shown to be the most effective in keeping our patients out of the hypothermia range. So, for example, keeping our patients above 36 degrees centigrade. Our rollout for our warming efforts started very early in 2020, just before COVID surged in our area. We began to do some product research and looked at facility agreements, what equipment we needed to bring in, what would need to be installed. We have 26 operating rooms and a number of offsite areas. We have a very large preoperative holding area and a large postoperative recovery area, and looking at needing to not only pre-warm, but also, of course, intra-warm, and then keep patients warmed postoperatively meant a large consideration for additional equipment. So we began to provide, in July of 2020, provide all the in-services that was needed. Now, we, again, are a large academic medical center with different subspecialties of nurses, of course, physicians, And we opted to do in-services by group. So for example, we have a team of nurses that focus on ortho, a team of nurses that focus on cardiac. We opted to go through in-services by group so people could learn together. In August of 2020, we launched our first efforts at utilizing a bear hugger warming gown and using that for a pre-warming phase, as well as using that gown intraoperatively and postoperatively. We relied on what was called the PDSA, a Plan, Do, Study, Act effort to guide our implementation. And what that really allowed us to do was to make small changes, do small implementations, and then evaluate our efforts. Moving forward, here's just an example of how we advertised and committed to education. You can see that there's multiple dates on this flyer that showed all the multiple in-services that we provided. We really wanted to make sure that folks got a chance to play with the warming gown that we chose to use, that they were able to work with it, ask questions, understand the benefits, really become familiar with the item itself, and also try it out, see if it made them feel warm, and if it was easy to place during different types of surgeries that require different positions. We got a lot of support from our 3M team for this. They came on multiple occasions to help provide the in-services. Having an education background, I break down challenges by looking at knowledge barriers, if there are any, systems barriers or motivational barriers. And midweek during our Go Live event, we stopped and asked everybody, patients and staff, if they understood what they were doing, if we were warming the correct way, if we were warming for as long as we wanted to, how we could make things flow a little bit better. So for example, our pre-op nurses are in one area of the facility and our post-op nurses are in another area, and we needed to get feedback from both of them. So we ran through and got feedback and buy-in and suggestions from each group of nurses, and as well as from anesthesia and from our surgeons. System issues that showed up, for example, was we didn't want the nurses to have to go from the patient's bedside to a supply cabinet to get the equipment they needed. So we set up all of the areas where the nurses could retrieve the items that they needed at the patient's bedside. Again, just looking at the intraoperative team, making sure that we were addressing the needs of the intraoperative nurse and team, who can become very busy with other patient care priorities such as airway management and documentation, really reinforcing that we wanted to get that gown plugged in as soon as the patient got into the operating room. To do this, sort of make sure that we were utilizing the equipment the correct way, we developed a very simple assessment tool, hopefully a non-threatening assessment tool. We made it purple, and it was just a 3-part question that they could answer themselves. And that was, did the patient arrive into the operating room with the warming gown on? Was the gown reconnected prior to induction of anesthesia? And then was the gown on during surgical prep? On the right-hand side, you can see this is our very initial rollout. This was our first rollout assessment. You can see that almost all the patients came into the operating room with the gown on. As we got into whether or not the gown was plugged in during induction, our compliance started to drift. And then during their surgical prep, you could see almost half the patients, 2/3 of the patients, were not connected. So we needed to sort of find out why we were moving away from our warming efforts as we got farther into the operative course. So many more questions, we had to ask. What we found out was that the nurses felt solely responsible, and they had so many other duties to take care of. So we really implemented team approach to this, including anesthesia and surgery. So, for example, we asked the nurses to be in charge of connecting the bear hugger warming gown when we first came into the operating room, and that anesthesia worked with the nurses by continuing, allowing the bear hugger warming gown to continue during the induction process, rather than insisting that it be turned off or removed. And then during prep, working with our surgeons to understand any concerns they had about utilizing forced air warming and during the prep process. So we really wanted to make sure that this was a team effort. When we were looking at how effective our implementation of the bear hugger warming gown was, we entered into our second PDSA. And what we discovered was, in looking at the data, that we were not necessarily avoiding hypothermia. Our patients, even with the bear hugger warming gown, as you can see in the chart to the right, that the patients were at some point experiencing hypothermia. In other words, that we were seeing temperatures dipping below 36 degrees. Looking at the data a little more closely, we found a couple of different things, and that was our thermometry methods. We were using, in the pre-op area, either an oral or axillary method. Intra-op, it was esophageal, bladder, nasopharyngeal, skin, and then post-op, it was almost always a temporal read. So we began to realize that perhaps our data was skewed by the type of thermometry method that we were using. So we opted to move into something that was called a peak assessment, which was offered by the 3M team. They came out with literally a team of 3 people, clinical specialists, who collected 90 observations to make sure that we were utilizing the item the way it was designed to be used, and that we were getting the best sort of bang for our buck, if you will. One of the goals in utilizing this forced air warming blanket was to reduce the use of cotton gowns and cotton blankets. So they spent 3 days with us, and they looked at 90 observations. And what we found was, in using a consistent thermometry method, which was a zero heat flux monitor that went on the temporal artery, we found that in fact we were avoiding hypothermia, and that our patients were staying above 36 degrees centigrade. So that was very positive. They did provide us some other additional information, and that is really focusing on getting our patients warmed for at least 10 minutes, pre-warming for at least 10 minutes. Again, connecting the patient right when we get into the operating room, and allowing that forced air warming to continue through induction. So that was a nice outcome study for us. Again, more recommendations, including educating the patients of the benefit of pre-warming. We did have patients that complained a little bit of getting too hot prior to the surgery. And then again, actively warming once we got into the operating room, and then continuing that process through the PACU. Now I'd like to transfer the talk to Kathy Ferguson, the ERAS coordinator at St. Martha's Hospital. Thank you.
Thank you, Dr. Cole, and hello, everyone. I appreciate this opportunity to be able to speak with you all today. As an ERAS coordinator, I certainly know firsthand the vital role that anesthesia professionals play in the successful implementation of any ERAS program, which of course includes methods to prevent perioperative hypothermia. As we all know, ERAS is now firmly established as a global surgical quality improvement initiative. ERAS combines the latest and best evidence to achieve rapid recovery outcomes without increased readmission to hospital or post-op complications. ERAS endorses 6 principles, and today I'd like to highlight 2 of those principles: patient and family engagement, as well as perioperative best practice, which includes patient warming. Success of the ERAS program relies on all of the components being implemented together. Therefore, promoting perioperative normothermia is crucial. And as anesthesia providers, you deliver many of these components. As Dr. DeBoer mentioned, evidence-based perioperative care is one of the cornerstones of ERAS. Evidence-based practice is also the cornerstone of perioperative nursing. Nursing follow national standards and guidelines, and these standards are developed by an interdisciplinary panel of clinical experts, including anesthesia professionals. So I've put 3 examples on the slide here. AORN, the American Operating Room Nurses Guidelines for Perioperative Practice, are considered the gold standard in evidence-based recommendations for delivering safe perioperative patient care. And also we have ORNAC, the Canadian standards, ACORN, the Australian, just to name a few. Implementation of these standards and guidelines allows the surgical team to provide safe, high-quality care for our patients. Each of these national standards and guidelines include recommendations for prevention of hypothermia. So as you can see, ERAS guidelines and these national standards go hand in hand. Because the ERAS approach begins before admission to surgery and continues post-operatively, a multidisciplinary team of healthcare professionals must collaborate to ensure successful implementation. Teamwork equals success, and I just wanted to share with you a picture of my team and some of the champions. The ERAS protocols require this dedicated and organized team effort, and as anesthesia providers, you play an important role in facilitating these protocols and some of the key elements. So one of the most important aspects of ERAS is the disciplinary team. So it's important when you put your team together that the team members are not just familiar with the ERAS principles, but they're motivated to carry out the program. And it's very important to identify your champions and your early adopters. So I wanted to share with you just a snapshot of our local implementation team to show you the various disciplines that we included. But I'd like to highlight not just the patient representative, but the family physician. So what we found is having the family physician included is important because they can support their patients by providing education and counseling, but they can also contribute to the prehabilitation of the patient because they know their patients so well. So successful implementation requires the collaboration and teamwork between your healthcare personnel, but you also have to include the patient. The patient plays a vital role in understanding and thereby facilitating the ERAS pathway. One of the many things I like about ERAS is ERAS places the patient first and makes them an active participant. Patient engagement is key to improving outcomes and enhancing the patient's satisfaction. The education of the patient needs to include the importance of pre-warming and how this is achieved. So when the patient arrives in the pre-op area, they should expect to receive their warming gown and understand why it's necessary. And it's also important to set out expectations early. In the surgeon's office, there should be a discussion about anticipated length of stay. The patient will be expected to be actively engaged, and giving them the bowel surgery booklet early allows them to formulate their questions so they have them ready when they arrive in either the pre-admission clinic or the anesthesia clinic. So we took our team and we came up with an interdisciplinary approach. So we tried to keep it simple. It's important that everyone knows their responsibilities. So we outlined 5 tasks for everyone. And as you can see, this also included the patient. So to help the patient be more involved in their care, we developed 2 tools. One was a meal tracker, and the second one was an activity tracker. So we tried to make the patient and their family members more interactive in their journey. So we made them responsible to keep track of their intake and also their mobilization. And I do have to say that with the ERAS program, taking the IV and the catheter, having the tubes out early, the family members felt more comfortable getting their loved ones up. So that was a big contributor for sure. So we also, of course, assigned 5 tasks for the anesthesiology providers. So these 5 tasks, of course, included maintaining normothermia. But as we all know, it takes a team approach. But Having anesthesia in the lead, you're guaranteed success. So data is out there. We're all well aware that maintaining normothermia is very beneficial to the patient, but implementing it is not always that easy. So we decided to do our own review at our site back in 2017 with the help of one of our industry partners. So as the ERAS guidelines and also the AORN guidelines recommend, patients should be pre-warmed 20 to 30 minutes prior to the induction of anesthesia. And there's various ways to achieve this. So prior to our study, we were using the warming gowns in the blankets in the operating room. But for our study, we actually adopted the warming patient gown. And I think as you can see in the picture, we chose one that was comfortable. The warming unit itself was very small. And I'm not sure if you can see in the picture, but the patient is actually holding the controls. So they can turn the temperature down if they become uncomfortable. Plus they can disconnect the small hose if they have to get up to the washroom. So it was important that the patient be comfortable with the gown. But what also was a great benefit to us was this specific gown actually turns into the warming blanket once you get into the OR. So it served double duty. So it was very cost effective as well. And that certainly helped us when we wanted to do our implementation post-study. So warming needs to be accompanied by precise and regular monitoring of the patient's temperature. So we wanted to choose a non-invasive, consistent, standardized temperature monitoring method that we could use throughout the whole perioperative process. So the picture in the slide actually shows the method that we chose, and it was very simple. It's non-invasive, and there's just a sticky monitor patch that goes on the patient's forehead, connected to a very fine wire. But what's really important is the temperature monitor connected very easily to our vital signs monitor. Our PACU nurses really embraced this after the study because they found that they could continually see the patient's temperature, quickly see any change, but they could in one glance see all the vital signs together. So our study was very positive. We saw a 42% improvement in the OR, and we also saw a 26% improvement in recovery room. And from the study, we came up with a summary of recommendations, which we adopted and we still follow to this day. And of course, one of them is maintaining the temperature between a certain range, but we also established a normothermia policy in each of the areas. We knew it was important to foster an interdisciplinary collaboration and culture. And we realized that we were all working within our own silos. So although each department and unit were giving great care, we really didn't understand and appreciate the work that each of the other units were doing. So we didn't really understand how our piece fit into the whole puzzle. So we had an interactive education day. So the morning was lectures, so we gave some information on ERAS, but the afternoon was all interactive stations. So we had stations right from pre-op, intra-op, post-op. As you can see, we did have a station to talk about patient warming and its importance. We also had a station for anesthesia, and they could discuss with the ward nurses different methods of post-op pain control and their importance. And we even had one of the surgeons take some of the instruments from the OR and bowel staplers. And in the intraoperative table, he showed the instruments, but he also showed a little video of MIS surgery. And I do have to say that this was a key turning point for us, having everyone on the same page. Everyone felt like they were part of the team. And this certainly was key to our success. And I have to say that after implementing our ERAS program, this continued on afterwards. So this is important, and we actually do an education day, a team education day, at least once a year. ERAS requires systematic auditing to improve outcomes. And auditing also helps you identify any pitfalls in communication or collaboration, and it helps improve compliance with the ERAS protocols. So we gathered our data two ways. We gathered red cap data, and for that we chose specific indicators. And as you can see, of course, normothermia was one of those indicators. What we found was that we saw an improvement in all the indicators, and we also saw an improvement in the patient experience. Our PI data was successful. We showed a reduced length of stay, a decreased return to the ER in 30 days, and a decrease in post-admission related to complications. So what we expected and what the literature said would happen actually happened. But what was really important was to capture that patient voice. We wanted the patient to be engaged and feel part of the process, but did they? So our NSQIP nurse collects data 30 days post-op, and she interviews the patient. She gets a lot of important feedback for us, but she also allowed us to add a couple of questions if there was specific information that we were looking for. So in the beginning, we asked her to add 2 questions. One was, did you feel part of the process? And the second was, what was the most positive part of your experience? And we were very happy when the feedback showed us that the patients felt well informed with all the steps. They felt their recovery was expedited, knowing all the steps. What was really important was they stated they felt like they were part of the team. So we continue to capture this patient's voice, and we're continuing to get these positive results. Right after our implementation, unfortunately, we were hit with COVID, and we worked our way through it. And what we've concluded is that post-COVID, if we can actually say we're post-COVID, making expeditious and uncomplicated recovery from surgery is even more important. ERAS implementation should be and needs to be part of the solution. The focus has to remain on providing better care, not just faster care. So what helped us get through this and what is helping us to continue to move on? The restricted in-person visit necessitated us to use more audiovisual technology for our patient education and counseling. And actually the patients are getting more comfortable with it and they like it. For the nursing staff, we found that those that had been educated and were familiar with ERAS, sustainability was maintained because these protocols were second nature. It had actually become the way we work. And for those nursing staff not familiar with ERAS, we made the protocols easily accessible. And what they found is that the order sets and the pathways clearly laid out expectations and goals, and the nursing staff truly appreciated knowing what to do and when to do it. And the one thing that the nurses commented on was, it's not more work, it's just a better way to do the work we do. And I think that's extremely important to all members of the surgical team, especially nursing, is that we're so bombarded with new programs, learning new things, and everyone is just stretched to the max right now. So having a way that just more organizes your work and knowing that it's not more added to your already busy work life is key. So in conclusion, ERAS has been proven to lower both recovery time and post-op complication rates while being cost-effective at the same time. And I have to say that certainly has been our experience. We've learned that patient engagement is key and the multidisciplinary approach is extremely important. And I do want to say that having anesthesia providers as leaders and champions will definitely ensure your success. So thank you so much for your time and attention. This concludes our first topic, and I would like to now turn it over to our Q&A portion. Welcome to our Q&A session. I would like to remind everyone to please submit your questions in the Q&A box. And I see we already have our first question. So our first question is, for the urgent emergent surgical patient, how best to incorporate emergency medical services into the ERAS team? So who would like to start? Dr. Cole, would you like to start as a clinician?
Sure, I can share just a simple implementation that we did for our group here at the LIC USC Medical Center. We're a large trauma institute. So from a normothermia standpoint, we opted to go with underbody bear hugger blankets. So for our trauma patients, for example, we would just have the warming device on the table, on the operating room table, as the patients arrived, and that has proven to be effective. When our patients come from the ICU, they've already gotten some other ERAS implementations incorporated, such as full body skin prep as well as oral care. So, but from a temperature standpoint, we use the underbody bear hugger warming blanket.
Thank you very much. Our second question has arrived. Have you heard from surgeons that the blower on prior to the prep and drape will increase the SSI risk? And is there data to show this is not the case?
Maybe I can take this one. Thank you. Thank you for the question. It's a very good question. And in the beginning of bear huggers, for instance, there was a perception that it could be a risk, an increased risk for SSI when you have the blower on prior to prep and drape. But there are data, firm data out there, which shows that this is not the case. So it's important to realize that these data are convincing and show evidence that there is no increased risk of SSI.
And can I add to that? Thank you for that, Dr. DeBoer. If you look at the data that tries to show that there is an increased SSI rate, the data is very weak, and there's not a lot. So I agree, but it's seemingly a longer conversation with our surgical colleagues to assure them.
Thank you very much, both Dr. DeBoer and Dr. Cole. So we have another question. Many patients find pre-warming to be uncomfortable since they may be waiting nervously for greater than 30 minutes if delayed. Any difference in outcomes of those patients that simply turn the warming devices off while waiting?
Maybe that's also a question I can take.
Thank you. Yes.
Yeah, sure. Thank you for the question again. I think it's an important question, and it's a question we are facing in the daily practice. So there are two things in it. I will take the last one because when you turn off the devices for waiting before your surgery, there is absolutely a risk that the patient is going hypothermic on the OR. And we know already that there is high evidence, and also the recommendations are that you should be very keen on hypothermia. But in the first part of the question, I think that's a key for ERAS and also for heat management, is that you educate your patients. And that you explain your patient, because the patient is one stakeholder in the whole ERAS journey of the patient, that the patient is aware of why he or she is doing this, and that this is beneficial for the outcome. And once you educate your patients well, the patients will take that as a rule. And the compliance of this is actually also in my hospital, for instance, very high.
And I can add to that as well. We've learned that long-term warming, greater than 45 minutes may not be that beneficial. And so just turning the bear hugger warming gown on, even 10 minutes prior to going to the operating room, as long as you're really truly warming them, it's a win-win. The patients feel more comfortable and you get the desired outcome.
Thank you very much. I also have to agree with what Dr. DeBoer said, and that is what we found is patient education, as I previously stated, is key. And once they understand the benefits and how important it is, I find they tolerate it a little better. And another tip that we found helpful was just to improve the communication between the operating room and the day surgery or ward to keep them updated if we had a delay. So that communication is key too, to prevent those long warming periods. So thank you. Another question, interesting lecture. In cardiac surgery, what are two most correct sites to monitor temperature? Who would like to take this one?
In our facility, the cardiac, the heart cases we're monitoring their temp via bladder using the Foley.
Okay, thank you very much. Another cardiac question here. Cardiac surgery, if cardiopulmonary bypass is used, there's only a need for normothermia after CPB, as patients will be cooled and rewarmed during CPB. That's a common quote. So, do you agree?
I don't have an opinion on this.
I can't comment this on this as well, because I'm not aware of this. So.
Yeah.
Me as well. So thank you for your question. Sorry we couldn't be of more help. So I think we'll try the next question. Thank you for an excellent presentation. What temperatures do you maintain in the operating rooms? Do you audit the OR temperatures as well? I'll comment on this first, and then I'll ask my colleagues if they would like to chime in. We have a protocol after the warming review that we did at our site. We actually document on every patient both the temperature of the room and the humidity in the room. And this again goes back to those national guidelines that I mentioned. And it's very specific what temperature range you should have and humidity you should have. So yes, we do collect this data, and we do monthly audits. And what about my colleagues?
Yes, but we are required to monitor both the OR temperature and the humidity in the operating room. And I want to share that the National Institute for Health and Care Excellence, the NICE guidelines, they also provide some guidelines for intraoperative OR temperatures. We adjust based upon the temperature of the patient and the exposure level. Our surgeons understand when we need to warm the room up. And then once we can get normothermia, established normothermia, then we can make the operating room suite a little cooler for the providers. But we make sure that our patients come first.
Well, it's the same. That's the same situation in my hospital, and there are national rules. Guidelines for this, and the OR temperature is continuously monitored, and we do also audits very frequently to keep the room temperature high.
Great. And I think too, again, this goes back to education and a lot for, the staff education as well. So especially during long cases, the staff can, especially with the extra protection that we had to wear, they do get uncomfortable. But again, it's all about the patient, right? So once everybody understands and is educated, it's much easier. And we have one more question here. What are the best ways to maintain the gain and ensure ERAS protocols continue to be followed after initial implementation?
So maybe I can take this one. I think this is a key question between the real ERAS versus the ERAS-like, because the best way to ensure that the ERAS protocols continue to be followed after initial implementation is auditing of your outcomes very strictly, and auditing your elements. And then you can also do the measurement and the monitoring regarding the compliance of the protocols. And once you can measure that, and when you're high with your compliance, you will see that your complication rate is going down, length of stay is going down, but also, your readmissions, for instance, and the quality of care will be increased finally. So it stands all not only implementing, but also to audit your outcomes, including the compliance of your ERAS protocols installed.
I agree with that. And data definitely drives the decisions, and from all levels of the facility, of course, patients, but providers as well as administration like to see that data. I think for us as well, we as we rolled out our ERAS programs, we wanted to make sure that everybody, the nurses and the anesthesia provider surgeons, felt a sense of ownership, especially the nurses who are prepping the patients. We really wanted to make sure we weren't micromanaging them. We wanted to make sure that they understood why things were happening. We created champions in each area, and that employee engagement has really paid off. In each area, people are, for example, in our urology, our gynecology educators, they really feel a sense of ownership, and they are innovating now. They look to see what is best for the patient and for their flow. And it's really paid off. It makes our ERAS sustainable, and actually makes those of us who are coordinating the ERAS projects, it honestly makes our jobs a little bit easier.
I agree with both my colleagues. And the auditing is so important, but sharing the results is also important. And as I said, we provide the feedback to all the different departments on a monthly basis. And when you do the auditing, you can find where you may be slipping and you can do better. So the auditing just kind of helps you monitor your progress. And if you start to slip a bit, you can deal with that. And I think, I guess that's the answer to the question. But
can I add to that?
Yes, please.
I want to just also, it's really important to make sure that it's easy for people to do their jobs. So that's making sure that you've got the supplies that you need. You've got your, whatever portion of ERAS that you're implementing, the focus of this talk is to prevent hypothermia or maintain normothermia, is to make sure you've got functioning equipment, so systems barriers are out of the way, and make sure that you've got no knowledge barriers, so ongoing education, which we've all addressed. I think making it easy for people to do their job is essential as well.
Great points. And also continuing your team meetings. So during the implementation, you have a lot of meetings, but to maintain those on a continuous basis is also, I would say, important as well. So we have one more question here. Do you recommend continuing the monitoring of body temperature even past the immediate perioperative period?
I can start with this one. Yes, temperature is a critical vital sign. So yes, you do want to make sure that you're continuing to monitor temperature past that point.
Very good. I agree with that as well. And as I pointed out during our education session for all the staff, our interactive day, by including those post-op nurses, the nurses on the ward, they became a lot more engaged, and that really helped. So I find that that has really increased after our ERAS implementation. Any other comments on that, Dr. DeBoer?
Yeah, I totally agree what's being said. So,
okay. Thank you all so much. I think that concludes our Q&A portion. So I would like to just say that there are two more great topics on for today. There's some amazing speakers, and we hope that you will stay tuned for an exciting and informative afternoon. So I'd like to thank my colleagues very much for this morning. And again, please stay tuned because there's a lot more great information coming your way.
Welcome back to Great Debates in Thermal Management. The faculty for this program are Kerry M. Cole, CRNA, Chief Nurse Anesthetist at LA County and USC Medical Center, and myself, Daniel Sessler. I'm Michael Cudahy, Professor and Chair of the Department of Outcomes Research at the Cleveland Clinic. In terms of disclosures, Dr. Cole is on the Speakers Bureau for 3M. I am a consultant for 3M, Calorant, Transconic, and Blue Spark. The program is provided by HMP Education, and it is supported by an educational grant from 3M Healthcare. The learning objectives for the following section are to know about true core temperature, monitoring sites, and which sites to use, also to understand normal thermoregulatory systems, including how they work, the importance of keeping surgical patients warm, including how to do that, and understanding the importance of ongoing education engagement in perioperative thermoregulation. Perioperative thermoregulation is controlled by a complex system. Afferent signals are detected by the skin, by tissues in the body, by the spinal cord and the brain itself. These signals go to controllers that are mostly in the brain, mostly the hypothalamus, and then the hypothalamus, when necessary, generates efferent signals, which include behavioral thermoregulation, that is how you consciously respond to the thermal environment, and then the autonomic responses, sweating, vasoconstriction, and shivering. Each of these responses has a threshold. That's simply the core temperature that triggers the response. And then it has a gain. That's how quickly the response increases. And then at some point, it reaches a maximum intensity for a given response. Normally, body temperature is very tightly regulated. So 37 degrees is average temperature in humans, although it varies with the circadian rhythm by about a degree over the course of the day. Normal temperature is defined by the region between the vasoconstriction and the sweating thresholds. This is typically just a few tenths of a degree. Temperatures exceeding the sweating threshold trigger sweating. Sweating is very effective, and it drives temperature back down to within the range between sweating and vasoconstriction, called the interthreshold range. Similarly, vasoconstriction is effective. So when people get hypothermic, they vasoconstrict, it constrains heat to the core, and that increases core temperature. The core temperature normally is defined by the difference between these two thresholds. The shivering threshold is a full degree below the vasoconstriction threshold. So shivering is very much a last resort response. During anesthesia, things change substantially. So this is a slide showing how desflurane, alfentanil, dexmedetomidine, and propofol influence the thresholds for sweating, vasoconstriction, and shivering. Please note that the entire previous slide fits inside the blue circle at the upper left there. So there's a very expanded scale here. General anesthetics and anesthetic drugs do not do much to the sweating threshold. The sweating threshold increases only slightly, but it profoundly decreases the vasoconstriction and shivering thresholds. So you can see at the upper left with desflurane, there's a huge decrease in the constriction and shivering thresholds. And similarly, at the lower right, you see a similar big decrease with propofol. Other drugs have a smaller effect, but pretty much all of the anesthetic sedatives and anesthetic drugs that we use profoundly impair thermoregulatory control. The consequence is that surgical patients in a cool environment become hypothermic. Hypothermia develops with a characteristic three-phase pattern. So initially, over the first 40 minutes or so after anesthetic induction, there's a precipitous decrease in core temperature. This is followed by a slow, linear decrease in core temperature. And finally, patients reach a core temperature plateau. And no matter how long the operation, no matter how big the operation, core temperature doesn't decrease any further. Each phase here results from a different cause, and I'll go through them in turn. The initial rapid decrease in core temperature results from an internal core to peripheral redistribution of body heat. The key to understanding this is that core temperature is not average temperature in the body. It's the temperature of the core, but the peripheral tissues, mostly the arms and legs, are 2 to 4 degrees cooler than core temperature. Now, I showed you before that all the anesthetics profoundly impair the vasoconstriction response. So as soon as you induce anesthesia, patients become vasodilated, and that allows heat to escape from the core out into the periphery. So that's good for the periphery. It warms up peripheral tissues, but it does so at the expense of core temperature, hence the rapid decrease in core temperature. The second phase of the hypothermia curve, that is the slow linear decrease, results from exactly what you would expect. That is heat loss exceeding heat production. And it's mostly radiation and convection, or evaporation and conduction contribute very little. And then finally, in patients who become sufficiently hypothermic, but note that this is about 3 degrees hypothermic, typically temperature around 34.5 degrees, patients vasoconstrict again, and that vasoconstriction is effective even during anesthesia, and it prevents further hypothermia. So ideally, patients don't get that cold, but if they do, they eventually begin to protect themselves. There are substantial consequences of hypothermia. So in terms of benefits, the only proven benefit of hypothermia in medical context is that it improves neurologic outcome after neonatal asphyxia. And therapeutic hypothermia has been proposed and tested for many other applications, and in large trials, it's failed in all of them. It doesn't mean that it doesn't work, but it had never worked in a trial yet, which means that it isn't working the way it's currently implemented. In terms of complications, the minor complications are decreased drug metabolism, because enzymes are very temperature sensitive, with consequent prolonged recovery. And unsurprisingly, hypothermic patients shiver and are uncomfortable. They feel cold. The potential major complications are coagulopathy, bleeding, increased transfusion requirement, wound infections, prolonged hospitalization, and morbid myocardial outcomes. So thermal discomfort, that's clear. So patients who are seriously hypothermic, in this case, 34.5 degrees after major surgery, took 2 hours to return to thermal comfort. That is, return to the point where they say, okay, I'm not feeling miserably cold anymore. I feel okay. Well, thermal comfort is not the most serious complication of hypothermia. It's not the most serious complication in general sense. But after all, we spend a lot of effort treating pain because it makes people feel uncomfortable, even though by itself, it doesn't cause any more serious complication. Same thing with thermal comfort. People hate feeling cold, and for no other reason, we should keep them warm. I mentioned prolonged drug metabolism. So this is an example of vecuronium. So these were volunteers. They were anesthetized twice, once at 36.5 degrees, once at 34.5 degrees. The duration of action of vecuronium was more than doubled at 34.5 degrees. To put this in perspective, the duration of action of vecuronium in a patient who is 2 degrees hypothermic exceeds that of pancuronium in a normothermic patient. Now, we've since tested a bunch of other muscle relaxants and other drugs. The effects are less impressive. We do not see a factor of 2 effect in other drugs, but we see 60% for other muscle relaxants. We see 30% for propofol. So these are clinically meaningful prolongations in drug action. Remember, we pay a lot to get short-acting drugs. If you let your patients get hypothermic, these drugs are no longer short-acting. They're longer-acting. So that doesn't really make sense. As a consequence, presumably, of delayed drug metabolism, patients take longer to recover. So this is fitness for discharge. And you read this horizontally. So the hypothermic patients took about 40 minutes longer to be ready to be discharged than normothermic patients. 40 minutes may not sound like very much, but remember, most patients stay in recovery for about an hour. So 40 minutes is a substantial prolongation of the normal recovery duration. I mentioned transfusions. So coagulopathy is the best documented complication of hypothermia, and there have now been many studies evaluating that. This is a meta-analysis of those studies, and it shows that patients who are hypothermic require more transfusions, and significantly so. And the amount of the increase is clinically meaningful. Your chances of needing a transfusion increase about 20% per degree of hypothermia. Wound infections have also been evaluated a number of times, all in relatively small studies. This is a meta-analysis of wound infection studies showing that hypothermia increases the risk for wound infections. All of the studies I just showed you, though, predate a study that was published earlier this year called the PROTECT trial. PROTECT was by far and away the largest trial ever in thermoregulation by a factor of 20 or something like that. It was a 5,000 patient, multi-center randomized trial. Patients had to have major non-cardiac surgery, expected to last more than 2 hours, be age 45 or greater, and have at least one cardiovascular risk factor. We randomized patients to a target core temperature of 35.5 degrees or to 37 degrees. The primary outcome was a composite of myocardial injury, arrest, and death. And the secondary outcomes were surgical site infection and transfusions. So the trial addressed all three of the major potential complications of hypothermia. Thermal management was excellent. So in patients assigned to routine care, where core temperature of 35.5 degrees, actual core temperature was 35.6 degrees. Now, some of you may be wondering about my use of the term routine care and 35.5. This study was largely conducted in China. And at the hospitals, we conducted the study in routine care, provided core temperatures of about 35.5 degrees. So it was routine where the study was conducted. In patients assigned to aggressive thermal management or target core temperature of 37 degrees, actual final intraoperative core temperature was 37.1 degrees. So we had exactly the expected 1.5 degree difference in core temperature. These were very long major operations. The average duration was about 4.5 hours in these patients. There was no difference in the composite primary outcome. That is the relative risk for a composite of myocardial injury, major adverse cardiac events, and death. Just absolutely zero effect. Furthermore, the confidence intervals are quite small around this relative risk of 1. So there truly was no effect. It's not an underpowered result. It is a true negative result. The same is true for the secondary outcomes. There was no significant difference and no clinically meaningful difference on surgical site infections, transfusion requirement, or hospital readmission. And once again, the confidence intervals around these values are relatively small. It's a true negative result, not an underpowered result. So what do we conclude? Randomization to 37 degrees versus 35.5 degrees core temperature during surgery does not reduce cardiovascular composite complications, although effectively this was just myocardial injury. We didn't have very many other cardiac events. Nor did randomization influence surgical site infections, transfusion requirements, duration of hospitalization, or hospital readmissions. What I conclude from this is that intraoperative temperatures of 35.5 degrees or higher appear to be safe. Put this another way, for a long time, we've used 36 degrees as the perioperative threshold for hypothermia. 36 degrees was pulled out of the air. There is no basis whatsoever for that number. PROTECT clearly indicates that it's too high, that the threshold for considering a perioperative patient to be hypothermic should not be above 35.5 degrees So in summary, general anesthesia profoundly impairs thermoregulatory control. Consequently, surgical patients become hypothermic, initially from redistribution, then from heat loss exceeding heat production. In terms of the consequences of hypothermia, it's bleeding, infection, delayed recovery in patients who are sufficiently hypothermic, let's say about 34.5 degrees. But we hope that most of our patients now are not getting that hypothermic. At temperatures above 35.5 degrees, we do not see any harm, with the caveat that we did not specifically evaluate duration of drug metabolism, duration of recovery, or thermal comfort. So it's possible that those minor consequences are still influenced by temperatures within the range from 35.5 to 37, but the major consequences are not. It's now my pleasure to introduce Dr. Cole, who will continue with the discussion.
Thank you, Dr. Sessler. Again, my name is Kerry Cole. I'm from the Los Angeles County USC Medical Center. I'm the chief nurse anesthetist and a fellow ERAS enthusiast. My section today is talking on the impact of inadvertent perioperative hypothermia, the causes and consequences, and what we can do about them. So prominent in the literature is the importance of pre-warming. And I particularly like this slide, this chart developed by Horn et al. In 2012. You can see that on the left-hand side is temperature, and of course the perioperative course is there on the bottom. You can see the blue line is no pre-warming, and it's pretty evident shortly after induction, after actually even entering the operating room, that the patient becomes hypothermic. You can see that the dark gray dotted line is actually 10 minutes of pre-warming, and it appears to be very effective in preventing the patients from becoming hypothermic. The 20 minutes of pre-warming is the green line, and interestingly, 30 minutes of pre-warming is the red line. So the take home of this slide for us in our institution was that 10 minutes of pre-warming was comfortable, or has been comfortable for our patients, and has been very effective in helping prevent hypothermia, this concept of heat banking, so that we can really help warm the periphery and the core prior to the patient entering the operating room. It's equally important to continue the warming during induction. We can see from Dr. Sessler's very nice graph that the first 30 minutes or the first hour into the operating room setting, especially during that period of induction where the patient becomes vasodilated and they have no internal thermoregulation left, that's really where that precipitous drop in temperature occurs. Once that drop occurs, it takes quite some time to get the patient warmed back up. So the heat banking through pre-warming in the preoperative holding area, and then keeping that warming device, that forced air warming device on during induction will really attenuate this drop, if not prevent it altogether. So additional studies show the importance of pre-warming that exists on PACU shivering and length of stay. This was a nice study from Becerra in 2019 that showed if you've got patients who are pre-warmed for 15 minutes, they compared pre-warming for 15 minutes, 30 minutes, and 45 minutes. And what they found, and they compared that to individuals that were not pre-warmed at all. The group that was pre-warmed for 15 minutes had no shivering at all in the PACU, which is fantastic. That means the patient has no thermal discomfort. There's not quite the same oxygen demand that occurs with shivering. And the likelihood of needing to use medications such as meperidine to reduce the shivering is gone. In addition, when patients are shivering in the postoperative recovery area, we may have to then put additional warming devices on them. So what this group found was that pre-warming for 15 minutes or 30 minutes was effective in preventing shivering. And they correlated that with a decreased length of stay in the PACU, which is a wonderful outcome of the pre-warming process. They interestingly found that if you pre-warm patients for 45 minutes, that some of the benefit of pre-warming actually goes away. And they thought about this in a couple of different ways, and that is maybe pre-warming for 45 minutes actually induces sweating, and that the sweating makes the patient more susceptible to cooling. So the take home from this slide for our group was that pre-warming for 15 minutes or 30 minutes was very helpful in reducing shivering and length of stay in our PACU, and we've actually found the same thing in our institution. Again, looking at teamwork, the importance of teamwork in the perioperative warming process, of the perioperative warming efforts for a medical center. Again, we're in a large academic medical center, a lot of competing needs for different providers. From the pre-op area, we really did want to strive to say that it isn't just fault on the pre-op nurse's responsibility to connect the patient and get them pre-warmed, that anybody coming to chat with the patient can connect the patient, the forced air warming unit, to the forced air warming gown when they're talking to the patients in the pre-op setting. So that could be the pre-op nurse, it could be an anesthesia member, it could be a surgeon. It doesn't just necessarily have to fall on the pre-op nurse. Same thing with the intra-op. So we ask our OR nurses to initially connect the patient's forced air warming unit to the gown as the patients come into the operating room. If they're busy, if they forget, then anesthesia can step up, surgery can step up, and make sure that the patient gets connected and is warmed during those critical points of time. Same thing in the PACU. We ask the PACU nurses to take the lead on it, but they can't be the only ones that are involved. So it really does require teamwork. And that has been a success point for us. To get there, we really need to make sure that everybody understands that we do in-services for all members of the perioperative team. So that brings us to the education. The front and center in the education process, or the number one stakeholder, really is the patient. So preoperatively, we remind the patients that they will be pre-warmed. We do tell them to bring warm clothes to the hospital. We tell family members to bring warm clothes to the hospital. It's cold in the preoperative holding areas. And for the patients, of course, it's cold in the operating room. So we make sure the patients are prepared to be pre-warmed and to do whatever they can to help that process. Now, not in any particular order, but we also want to make sure our administrative colleagues understand that this is also a high priority. And that means making sure that we have the supplies necessary. We don't want supply chain issues to get in the way of good patient care. So we really keep our administrative colleagues close to this process. And then surgeons, nursing, and anesthesia, we all have our specific roles in the perioperative setting, but there needs to be some common goals. And one of the common goals is, of course, keeping the patients warm and therefore reducing our surgical site infection, reducing thermal discomfort, reducing length of stay, increasing patient outcomes or improving patient outcomes, and making for a much happier client. So everybody gets educated in our institution on a regular basis regarding perioperative temperature management. Then there's occasionally we have a gap in our performance. And so we have to look at this as an educational gap. It isn't, and most of the gaps that we see in our performance can be analyzed. And this is the technique that we use. So number one is consideration is there a knowledge barrier? Do people understand what they're doing and why they're doing it? We are, again, in a large academic institution. So guaranteed July 1st, we have a big turnover in personnel. In addition, we have been experiencing bigger than normal turnover in nursing staff. So we have to remember that we have new faces, new providers, and that knowledge is going to be one of the barriers that we'll experience in rolling out efforts to reduce hypothermia. So we make sure that we have in-services for all providers and on a regular basis. We also want to make sure that the ERAS team is available to everybody. So if you have questions, our numbers are plastered everywhere. We have cognitive aids put up in the operating rooms and in the hallways, trying to reduce any questions about why people are doing what they're doing. And then there's organizational barriers. So for example, do we have all of the equipment necessary? Is equipment functioning like it should be? Do we have a good way to get equipment serviced if it needs to be? If we're running low on the forced air warming units, can we utilize other units from other areas? So looking at minimizing any organizational barriers. The last barrier that needs to be addressed is the motivational barrier. And I do want to say lots of times we make that motivational barrier the first barrier. We talk about, oh, they just don't care, or they're too busy, or we tend to put a personality to this process. And actually, motivational barriers are only born out of two things, and that is if somebody doesn't know what they need to do, so that would be a knowledge barrier, or if you put up too many walls, too many system issues, so that they can't do what they're supposed to do, then you breed a motivational barrier. But you really need to take care of knowledge and organization first. All right, this is our chance to get to our Q&A session. Thank you very much, and we look forward to chatting. Thank you for joining us this morning. Thank you, Dr. Sassler. This opens our question and answer session. I really encourage anybody to enter your questions. We're here to address them. Dr. Sassler is an expert in thermal management and regulation. So we're here to answer questions about implementation as well as the latest in the research. So please send us your questions. I can start. I have a question for Dr. Sassler. In our implementation of really making sure that patients are normothermic, or continuing our efforts to make sure that patients are normothermic, we did use for a brief period of time the zero heat flux temperature device, which was the RON sticker we placed on the temporal forehead. We found that it was really nice to use because it gave us a consistent measure from the pre-op, intra-op to post-op setting. And I wanted to get your thoughts on that, your opinion about that particular zero heat flux monitoring device.
Okay, with pleasure. Excellent question. Zero heat flux monitoring is well known, well established, and well validated. So it clearly works. There's currently only a single device available in the United States, and that's from the 3M Spearhugger temperature monitor. We actually did the original validation on it. Others have looked at it since. Unsurprisingly, it works, since the general theory of zero heat flux monitoring has been known since the 1950s. It's a very attractive device because, as Kerry mentioned, you can put it on preoperatively and leave it on through surgery and then into the post-anesthesia care unit. So it's a great device. If you have it, by all means, use it. The most important time to measure temperature, though, is intraoperatively. People are nearly always normothermic when they come to surgery. Unless patients are terribly sick already and coming from an ICU, they're going to be normothermic when they show up for surgery. Then they get hypothermic during surgery if they're not adequately warmed. And then people recover relatively quickly in recovery. So the critical period for measuring temperature really is intraoperatively. The best intraoperative measures are esophageal and nasopharyngeal. They're true core temperatures, they're easy to use, they're inexpensive, and they're resistant to artifact. So if you want to use zero heat flux, that's perfectly acceptable. By all means, you can put it on preoperatively, keep it the whole time. But if you're just going to focus on the intraoperative period, nasopharyngeal or esophageal would be preferable.
Okay, thank you. Okay, so here we go. Is there a how to word this? Is there a time frame where patient is hypothermic intraoperatively, 15 minutes, 30 minutes or more, where the risk factors increase? Have we done any studies to look at the length of time a patient is hypothermic, where the risk factors begin?
For hyperthermia.
Hypothermic.
For hypothermia.
Hypothermic, yeah.
Okay, well, hypothermia develops rapidly right after induction of anesthesia because of the cortical-peripheral redistribution. So the fastest decrease in most patients is, say, in the 30 or 40 minutes after induction of anesthesia. Thereafter, there's a slow linear change in core temperature. And the change can be positive if patients are being actively warmed because more heat is going in than is leaving, or patients can stay the same, or more commonly, if they're not actively warm, they gradually become hypothermic. And that continues until they're quite hypothermic. If you let them get really hypothermic, vasoconstriction kicks in again. But that doesn't happen until patients are at about 34.5 degrees. So you really don't want to use that. You should be keeping your patients a lot warmer than that.
Okay, and here's another question. Fluid warming. What's your take on fluid warming?
Okay, you cannot warm patients by warming the fluids because you can't heat the fluids to much above body temperature. On the other hand, you absolutely can cool patients by giving cold fluids. And the amount of cooling is about 1/4 degree decrease in mean body temperature per liter of crystalloid at ambient temperature or per unit of blood from the refrigerator. They both have the same cooling potential. So if you're giving large amounts of fluid, you should warm them. If you're giving small amounts, whether blood or crystalloid, then there's no need to warm fluids. If you're only giving 1 liter or 2 during the entire case, fluid warming is not a good use of funds.
Okay, thank you for that. We can allay our surgeons' concerns or our perioperative team concerns with the use of the forced air warming devices, even during prep.
I'm sorry, your question was about using them preoperatively?
Using the forced air warming devices during prep, is that still, in your opinion, acceptable?
During prep?
During surgical prep, having the forced air warming device
okay, during surgical prep. Yeah, there's no evidence to believe that it's harmful or dangerous to use it during the preparation period.
And from our perspective in my medical center, same thing. We encourage we use the forced air warming device. As we've moved into pre-warming and really encouraged the use of it during induction and during prep, we've seen a significant improvement in our in reducing instances of hypothermia. We're constantly monitoring our patients, trying to keep them above. Currently we're trying to keep them above 36. I will reread the Lancet journal, the Protect trial, and readjust.
The threshold really should be moved to 35.5. The Protect trial, it is absolutely clear. It evaluated all the substantive complications, putative complications of hypothermia. There was no difference at core temperature 35.5 and 37 degrees. So there's no basis for 36 degrees. 36 degrees was literally pulled out of the air. And it can't be supported at this point. That said, a threshold of 35 is not permission to let everybody get to temperatures below that. You still need to keep people at least 35.5. And in most cases, that will require active management.
Right. And then this question came up in our last presentation, but it was on the topic of trauma patients or urgent emergent cases. And we talked about the use of the underbody forced air warming devices. Any opinion on that? The use of the underbody when, say, perhaps you cannot use an overbody?
Okay, so the question is about underbody warming. There is no underbody forced air warming. You can put a cover under the body, but the body squashes the cover, so there is no forced air warming under the body. All the warming from a so-called underbody cover comes from air around the sides. And that's probably sufficient because there's not much heat that's lost from the back into the surgical table, which is protected by 2 inches of foam insulation. So heat is lost from the anterior surface anyway. And what happens is that there's enough heat, warm air delivered around the sides of the patient and then is trapped by the surgical drape that it turns out to be an effective way to warm people. But calling it underbody warming is a little bit of a misnomer. The cover is under the body, but the warming is all anterior.
Thank you. And as we wait for additional questions to come in, any other pearls of wisdom that you can share with our listeners?
Most patients still require active warming of some sort. It's possible that you can keep some patients normothermic, which I would say now is 35.5, without actively warming them. If so, that's fine. I mean, the rule is not that you have to use some particular warmer. The rule is that your patient should stay above 35.5 degrees. How you do that's entirely up to you. I will comment on pre-warming. Pre-warming works. It just doesn't work very well. So in meta-analysis, the effect of pre-warming was to prevent about 0.4 degrees of hypothermia. Okay, it's not zero, but it's not very much either. So if you want to use pre-warming, absolutely feel free. It's a perfectly legitimate thing to do. But you shouldn't come away from this concluding that pre-warming is standard of care or that you need to do it. That's just not the case.
All right. I think this wraps up our session for this second session. And if there's no additional questions, then I think we will, or do you have any comments, Dr. Sessler, or shall we move on to the next discussion? We hope that the group will stay for our third and final talk for today.
No, let's move on.
Okay, that sounds great. Thank you so much. Please stick around for the next discussion. I'm honored to be speaking with Dr. Sessler and sharing our experiences both in his research and in our implementation.
Welcome back to Great Debates in Thermal Management. Your faculty are Kerry Cole, CRNA from LA County, USC Medical Center, and myself, Daniel Sessler, Professor and Chair of Department of Outcomes Research at the Cleveland Clinic. We both have some disclosures, mostly 3M and some other thermoregulatory companies. And this program is provided by HMP Education, and it is supported by a grant from 3M Healthcare. Our learning objectives are globally to be able to describe the effects of general anesthesia on warm and cold responses, to understand the causes of various hypothermia phases during anesthesia, to understand the importance of temperature monitoring, and finally, understand the importance of maintaining patient safety and standards of practice. Let me start by talking about temperature monitoring. There are 4 reliable core temperature monitoring sites: pulmonary artery, distal esophagus, nasopharynx, and the tympanic membrane measured with a thermocouple. Other sites that are generally reliable are the mouth, the axilla, bladder, and something called zero heat flux thermometry, which I will discuss in some detail. Suboptimal sites include forehead skin. Forehead skin is not the same as core temperature. And furthermore, the difference between skin temperature and core temperature varies as a function of the patient, vasoconstriction, and especially environmental temperature. So you can't just take skin temperature, add 2 degrees, for example, and turn it into core temperature. infrared tympanic temperatures, and I use that in quotes because the infrared sensors don't go far enough into the ear to get anywhere near the tympanic membrane. It's actually just measuring skin temperature inside the ear canal. And infrared temporal artery thermometers and rectal temperatures are all unreliable. Rectal temperature, I know, is commonly used. It can be equal to core temperature, but it has a very long lag time, and therefore it's unreliable during the perioperative period when temperatures are changing quickly. Nasopharyngeal temperature is a great place to measure temperature. The most obvious place to measure temperature is in the distal esophagus. So in intubated patients, the surgeons aren't working on the esophagus. An esophageal probe is drop dead the most obvious thing to use. It's simple, it's inexpensive, and it's highly resistant to artifact. But if you can't use esophageal temperature, then nasopharyngeal temperatures are just as good. But there's a detail about nasopharyngeal temperatures, which is that you need to insert the probe at least 10 centimeters. 10 centimeters, that's about this long, is deeper than most people think. If you don't insert it that far, the temperatures are unreliable. Now, I promised to tell you about zero heat flux thermometry. This is not a new technique. It was invented in the 1950s by a guy named Fox, and it's been available since then. It's well validated, and the system works. However, it's not been available in the United States until relatively recently, maybe a decade ago or so. The way it works is that normally core temperature is higher than skin temperature. On average, it has to be higher because the second law of thermodynamics says that heat can only flow down a temperature gradient. If there were no gradient from the core to the skin, heat could not leave the core, get to the skin, and be dissipated to the environment. It would just collect in the core and we'd get hotter and hotter. So you know that there's a gradient there. So that's the normal situation. The way zero heat flux thermometry works is it creates a perfect insulator over the skin surface. Now, perfect insulator sounds like something that's magical and impossible, but it's not magical and it's not impossible. It's absolutely possible to make a perfect insulator. And the way you do it is you take an insulator, and it doesn't even have to be a very good insulator, but you take some insulator and then you put a heater above the insulator, and then you put two thermometers, one on the skin surface and one inside the heater. And you servo control the heater so that the temperature of the heater is exactly the same as the temperature of the skin surface. Okay, well, I just told you the second law of thermodynamics. There cannot be any flow of heat if there's not a temperature gradient. So if the temperature of the heater and the temperature of the skin are exactly the same, you have a perfect insulator. By the second law of thermodynamics, there can't be any flow of heat. And therefore, warmth that's coming from the core up towards the skin surface hits this perfect insulator and it bounces back. And what you end up with is what's called an isothermal tunnel. That is a region of core temperature that extends all the way to the skin surface under the insulator. Now, it doesn't work exactly perfectly because there is also lateral flow of heat in capillaries and blood vessels. So it's not absolutely perfect, but it's pretty good. It's been validated lots and lots of times, and it's a perfectly reasonable way of taking the temperature. It's a great advantage of being completely non-invasive, and therefore you can start preoperatively and continue with it postoperatively. I mentioned before that rectal temperature is a poor way to measure temperature, and here's why I say that. So in this study, we took swine, human-sized swine, and we gave them halothane and succinylcholine at time 0. This reliably triggers malignant hyperthermia. And if you look at the very top, you can see esophageal temperature. Within 15 minutes, esophageal temperature was increasing, and it increased very rapidly thereafter. So if you're doing a case and you saw this increase, it would certainly alert you that something was going very wrong, and you would check for malignant hyperthermia. Now let's look at rectal temperature. So that's the other curve that starts at the left top. Rectal temperature remains unchanged during this malignant hyperthermia crisis. And by the end of this graph, the pH was something like 6.7, PCO2 was well over 100, and the pigs were trying to die. Rectal temperature was normal. It's not helping you. So rectal temperature is a poor temperature in the perioperative context because it won't give you an indication that your patient has malignant hyperthermia, which is one of the important reasons for measuring temperature. So now let's go on and talk about how to maintain normothermia. Okay, well, one way is to keep the room warm. And we know from, say, pediatric anesthesia, if you increase the temperature of the room sufficiently, you can keep any patient warm. The trouble is you make absolutely everybody in the room miserable. And maybe people put up with that for pediatric anesthesia, but for adult patients, the surgeons would be pretty annoyed. But it does work. Final intraoperative core temperature differs as a function of room temperature, of course, with higher room temperatures giving you higher final core temperatures in unwarmed surgical patients. If you warm patients with forced air, it turns out that ambient temperature makes no difference at all. That might initially sound surprising, but if you think about it, a surgical patient doesn't see the room. What the surgical patient sees is the temperature of the forced air cover. And so if you're actively warming patients with forced air, it makes no difference whatsoever what the room temperature is. You can turn it down to a level that's comfortable for the surgeons and hopefully not too uncomfortable for the anesthesia staff. The easiest way to reduce heat loss in surgical patients is to cover them with some passive insulator. And every operating room has lots and lots of insulators hanging around. So you can use plastic bags, you can use cotton drapes, cloth or paper surgical drapes, or you can pay extra and get some fancy reflective thing like a thermodrape. They all work. They all reduce heat loss by about 30%, which is very much a clinically meaningful reduction in heat loss. But they all work about the same. There are no clinically meaningful differences among these different passive insulators. And the reason is that it's not actually the layer of insulation that protects against heat loss. It's the little bit of air that's trapped below the cover that provides the insulation. And therefore, it doesn't matter very much what the cover is made of. So don't pay extra for a special reflective drape. Just cover patients with whatever is handy and cover, of course, as much of the patient as possible. Remember, they don't work by magic. They only work on skin that's actually covered. So if you can keep your patients normothermic with passive insulation, that's great. That's all you need to do. Remember, the rule is you have to keep your patients above 35.5 degrees, not that you have to use any special technique. But most patients, you'll need to use something else. And what most people go to is forced air. Forced air is not the only way to keep people warm. There are now many active warming systems. I do not care which ones you use. You are absolutely free to use any sort of active warming system or passive system, so long as you keep your patients normothermic. So it's up to you to keep patients warm. How you do it is entirely your prerogative. But that said, worldwide, about 90% of active intraoperative warming is with forced air. And for good reason, because forced air is inexpensive, it's easy to use, it's effective, and it's absolutely drop dead safe. It's virtually impossible to burn somebody with forced air. Pre-warming is something else you can consider. So remember, in my previous talk, I talked about redistribution hypothermia. So right after you induce anesthesia, there's this precipitous decrease in core temperature, typically a degree or so, that results from this internal core to peripheral redistribution of body heat. It's very hard to treat it because it's a large flow of heat and it's happening deep inside of the body, but it can be largely prevented. And the way to prevent it is to pre-warm patients. So if you actively warm patients before induction of anesthesia, their bodies absorb heat. Core temperature doesn't change, Remember, core temperature is regulated. They're not anesthetized yet. So they will start to sweat if necessary to protect their core temperature. So you don't expect pre-warming to change core temperature, but the heat that you're applying to the skin surface is absorbed by the body. And the result is that you have a smaller core to peripheral tissue temperature gradient, and therefore a smaller flow of heat and less redistribution. So that's the theory. Does it actually work? Yes, it does work. It just doesn't work terribly well. So this is a meta-analysis we did showing that the average effect of pre-warming is a 0.4 degrees reduction in intraoperative core temperature. 0.4 degrees is not very much. So if you want to use pre-warming, by all means use it. It's a legitimate technique, and a few centers use it, not very many. So it's fine. If you want to pre-warm patient, feel free. It's just that it's not going to buy you very much. You'll only get a few tenths of a degree benefit from it, which in the scheme of things is not terribly much. Fluid warming is interesting. So you cannot warm patients by warming fluids. And the reason is that you can't warm the fluids to very much above core temperature. So even if you're giving very large volumes, the amount of heat transferred into patients is small. On the other hand, you sure can cool patients by giving large volumes of cool fluid. A liter of crystalloid at ambient temperature decreases mean body temperature by 1/4 degree in a typical sized adult. 1 unit of blood from the refrigerator also reduces mean body temperature by 1/4 degree. It's half the volume and twice as cold. That's why. So a corollary is that it does not make any sense to give, say, 5 liters of unwarmed crystalloid and then hook up a fluid warmer to give 1 unit of blood. If you're giving large amounts of fluid, whether blood or crystalloid or colloid, then you should warm the fluid. If you're giving small amounts, it doesn't matter. It won't help you. It's just wasted money for small amounts of fluid. So use fluid warming when you're giving large amounts of fluid. Otherwise, just don't bother. So to summarize here, the core temperature monitoring sites are the pulmonary artery, esophagus, nasopharynx, and the tympanic membrane with a thermocouple. Effectively, this is not clinically available. So you really have only 3 sites, and the pulmonary artery is rarely available. So esophagus and nasopharynx are your go-to sites. If they are available, those are the sites you should use. If they're not available, and I recognize they're not in many patients, let's say patients having a neuraxial anesthesia who still get hypothermic and still should be monitored, then you need some other site, something like oral temperature, axillary temperature, zero heat flux are good alternatives. You need to maintain normothermia with perioperative normothermia on the basis of the PROTECT trial, defined as any core temperature of 35.5 degrees or higher. Anything above that is fine. The threshold for perioperative hypothermia needs to be redefined. It's 35.5 degrees based on PROTECT, not 36 degrees as we were all taught. How you keep patients normothermic is entirely up to you. I could care less how you do it. I care a lot that you do, though. So your patients really need to be at least 35.5 degrees because lower temperatures provoke complications. How you get there, it's your business. Any way you do it is fine. As I mentioned, forced air is by far the most common, and it's what I use and the Cleveland Clinic uses, but whatever you use is okay. Fluid warming should be restricted to patients who are getting large amounts of fluid. It's just not valuable if you're only giving small amounts of fluid. And with that, thank you much. And it's my pleasure now to introduce Dr. Cole, who will continue with our great debate.
Thank you, Dr. Sessler. Again, my name is Kerry Cole, fellow ERAS enthusiast, and my discussion is going to be the great debates and updates in temperature monitoring. This is just a snapshot of the data that we collect to measure and evaluate how our warming protocols are going. It's a busy slide. The data is rich, and we want to pull out, we initially want to pull out more data than we think we need so that we can have it available just in case, so to avoid that we don't go back into the patient's chart and have to hunt and look for data again. So this snapshot just basically looks at the variety of cases that we do. So hysterectomies, and then some urology cases, some liver cases, minimally invasive procedures. We found that looking at age and weight was a factor. Patients who are older may tend to be a little colder perioperatively. So we have factored that in. We look at, we make sure that we know the temperature method. So for example, in this OR temp key to the right, you can see that we have on occasion that the provider hasn't indicated how the temperature monitoring went, like it's undocumented, versus say axillary, bladder, esophageal, nasopharyngeal, or skin. And skin could be on the forehead. It could be somewhere on the body. So we discovered pretty quickly in our data that, like I mentioned earlier, that we have a really wide variety of ways to, our thermometry methods really vary. We also look at, when we're looking at our data, what warming methods are we using? So in addition to just a warm sheet or a warm blanket, did the anesthesia provider utilize a fluid warmer? Are they using a lower body warming gown? Is it not documented? Is it a total full body warming gown? Is it an upper body warming gown? We have all of those available to us in the operating room, and those methods definitely influence our outcome. What I wanted to share about this was our snapshot of data early on in August of 2020. In addition to continually educating and re-educating the perioperative staff and faculty and providers, we know that it's important for us to constantly look at the data. This is because data drives our decisions. So we just finished data collection for the period of January 1st of this year through June 30th. And this was a bit of a wake-up call for us. The areas in red show that we are still, that quite a high percentage of our patients are still experiencing hypothermia perioperatively. It's usually in the operating room, and it's generally after induction. So we have what I'd say is raw data to work with. I want to point out that we added a few extra factors in looking at our temperature, and that was, did our patients, comparing patients who became hypothermic with just general anesthesia alone versus hypothermic with patients that were general and a regional combination. We know regional has its own, I'd say, risk factors in patients developing hypothermia. And then we looked at if there were additional procedures being done. So in this case, the percentage of patients that became hypothermic when there was an arterial line or central line placed. And the thinking behind this was to ask ourselves, are we focused on getting a line placed, like an arterial line or a central line? And are we less focused on monitoring the patient or addressing the patient's hypothermia during that period? And that's would be a human factor condition to think about. What that means for us, and we don't know yet, we'll take this data and we'll ask our providers and our staff. We'll begin to make some observations throughout the perioperative course, look to see when patients are getting cold, look to see what modalities are in place, what warming modalities are in place at certain times. For example, if somebody is placing a central line, they may opt to ask to have the bear hugger turned off, or they may have forgotten to turn the bear hugger on, or they may want to have a lower body bear hugger. So these are the kind of factors that we will drill down in and figure out why, for example, when we're putting on additional procedures, there's a greater percentage of patients who are getting cold. I think we know the answer, but we need to ask our providers and make a handful of observations or a number of observations to make sure that our data is moving in the right direction with the right conclusions. So, but this is a little bit of humble pie for us to see that we have, 61% of our cases still have episodes of hypothermia. One of the big factors here is, again, could be our thermometry method. So we will probably run a trial in the next month or so, try to collect a couple hundred patients and use a different thermometry method to make sure that we are in fact avoiding hypothermia, or we'll rule in that we have a bigger problem that we realize. So I share this with you because this is an ongoing process. It's something that takes time, the data management, finding individuals to go through the patient's charts, to look at the data, look at all the factors that are involved. It does take time. This is that piece where we get request additional help from, say, for example, administration. We want to make sure that we have good data. We need to dedicate time and personnel to this. And we also really want to make sure that we are cataloging and preserving this data. We have spreadsheets that we use. We actually back them up on hard drives so that we don't accidentally lose them. This data is very valuable. Again, it really drives our decisions. I've presented this similar slide in the last discussion, but just to say the benefit of looking at thermometry, what we anticipate with the previous slide, once we look at changing our thermometry method to being consistent throughout the entire perioperative course, we're hoping that we, in fact, can avoid hypothermia. And if not, then that just means that we need to do a little bit more education and more in the way of in-servicing, and not just using forced air warming gowns. We did notice in the last couple of months that our use of fluid warmers declined a bit. Not sure why, other than maybe more novice learners in the area right now focusing on important tasks such as airway management. So utilizing additional help, so for example, our anesthesia technicians, get them involved in setting up fluid warmers for our patients. Every little extra bit of effort will hopefully result in a very positive outcome. It's also important just to review and reinforce our standards of practice, whether it be the American Society of Anesthesiologists, the American Association of Nurse Anesthetists, the American Operating Room Nurses Association, the Anesthesia Patient Safety Foundation. There's so many areas that highlight our standards of practice and patient safety. So, for example, from the American Society of Anesthesiologists and the American Association of Nurse Anesthetists, the statement basically says, during all anesthetics, the patient's oxygenation, ventilation, circulation, and temperature shall be continually evaluated. So temperature really is a critical modality that we need to monitor. Lots of places have provided guidelines. We've talked about those, enhanced recovery after surgery guidelines, the NICE guidelines for prevention of hypothermia. And it includes recommendations for patients' body temperature, selecting methods for prevention of unplanned hypothermia, and implementing the selected insulation and warming interventions. So it's very important to reinforce the standards of practice and address any questions, but really, this is what we're held accountable for. All right, that ends our section on, now we can move on to the question and answer session. Thank you. Thank you, Dr. Sessler, and thank you to the team that's joining us this morning. This opens our Q&A session. We hope that you'll submit some questions for us. We're here for you. Our first question has come in, and the question is, for emergent surgical patients arriving via the emergency department, for example, elderly found down at home for an undetermined time down, including cold weather trauma. Do you have any tips or caveats, i.e. best practices for early in the field and on arrival to emergency department regarding monitoring and training the teams to help ensure, at the minimum, having the patient normothermic on arrival to the OR? So that's a great question and multiple parts. Dr. Sessler, do you want to start with this one?
Okay.
Cold elderly patient found down at home and it's cold outside.
Okay, so this is in the broad category of patients who get hypothermic before they come to surgery. So that includes military situation, it includes accidental hypothermia, and it includes patients who have a stroke or fall or otherwise are at home and get hypothermic before they come to the hospital. This is a challenging situation for everyone because these patients are often quite hypothermic. The amount of heat they've lost is substantial, and getting that much heat back into them is difficult. Furthermore, we mostly have access to the skin surface, and it takes a fairly long time for heat to move from the surface into the core, which is the part of the body that you really care about. So for patients who are really cold, say in hypothermic arrest, you need to use bypass. All right, that if somebody comes in at, say, 28 degrees in cardiac arrest, only bypass is going to rewarm them quickly. And bypass has the huge advantage of warming the core rather than the periphery. But for your more typical patient who's, say, 34 or 33 degrees, then you still probably will use surface warming. Forced air or a combination of forced air and resistive heating is helpful. There are book chapters saying take these patients and drop them into hot water. People who write that have obviously never done it. I've done it, okay, as a series of volunteer experiments. We set it up. It took weeks to prepare an operating room so that we could actually drop somebody into water. It's not that easy. And because of electrical reasons, it's not that safe either. So generally, I don't recommend trying to drop people into warm water. So probably you just do the best you can. Surprisingly, individual patients normally do okay. So statistically, you will have more complications in hypothermic patients than in normothermic patients. That's why we don't allow surgical patients to become hypothermic normally. On the other hand, an individual patient shows up at, say, even 32 degrees or lower. They normally do okay. It takes a long time to rewarm them. Be careful. They're subject to cardiac arrhythmias, but normally they actually do okay. I've taken lots and lots of volunteers down to 34 degrees or less, and they do fine. So that's a very long answer to saying just warm them as best you can. A combination of forced air and resistive heating would be a good one. Don't do things like put hot water bottles against their skin. It doesn't transfer very much heat, and you reliably will burn people. Just don't do that.
We thank you for that. And the other thing I want to add to that is in our emergency department, we haven't initiated forced air warming as a regular practice. It is being done when we have patients who are coming in who are hypothermic. In our, what we call surgical observation unit, we're starting to routinely pre-warm our patients, unless of course they're hyperthermic. But I think that from our standpoint, when we get elderly hypothermic patients, same thing. We try to use multiple modalities. Don't get too aggressive, like Dr. Sessler mentioned. Please don't inadvertently burn your patients. But using what we have, getting the blankets on our patients, trying to warm them as much as possible before coming into the operating room. Of course, some patients are absolutely emergency cases. We don't have that luxury. But when you do have time, take a moment to warm them before they get into a cold operating room environment, warm up the room, and so on and so forth.
Let me comment that emergency departments should have a forced air warmer.
Yes.
It's
yes.
not rare for patients to come in hypothermic, even patients who haven't had much exposure. Elderly people who fall at home and are down for hours or days will come in hypothermic. That's absolutely normal. Forced air is the easiest, safest way to warm people in the emergency department. I have personal experience with it. I was in an SUV that flipped over in Austria and broke my collarbone. I thought I had a pneumothorax, and they took me by helicopter out to the local hospital, and it was raining during this time. It was not terribly cold, but it was raining. I was wet. By the time I got to the hospital, I was really quite hypothermic, and I was so glad to see a forced air warmer. You can't imagine.
That personal experience, I was going to mention that in our last discussion. If you've been cold in an operating room or in a perioperative setting, you remember it. And I think that's often what drives us to kind of help prevent others from experiencing that. It is a horrible feeling.
Yeah, and the memory doesn't fade. It's interesting. The memory of pain after surgery fades.
Yes.
So as you ask people, 6 months, a year, 2 years out, after a while they say, oh, it wasn't that bad, even if it was terrible. You ask them about thermal discomfort after surgery, they will tell you in great detail about it a decade later. Somehow that uncomfortable feeling doesn't fade.
All right, thank you. Our next question is coming in, and that is, what are your recommendations for patients that are entering the OR with a fever/infection?
Okay, that's a great question. There's exactly zero data to support an answer. On the other hand, I'll give you my answer, which is don't do anything. Don't try to cool them, and don't warm them either. They're okay. If they start to get hypothermic, which could happen during a long surgery, because remember, anesthetics block thermoregulatory control, including fever. We've studied this in great detail in volunteers. So if they start to get hypothermic, prevent that. If they're not hypothermic, though, just don't do anything. There's no need to try to defend their current temperature or to reduce it to what you would consider to be normothermic. Their febrile temperature is normothermic for them.
Thank you for that. And I would agree, in our institution, we don't aggressively treat a patient that is, has an elevated temperature. And like you said, if a patient's hyperthermic, we may need to rule in some other things other treatments that are needed. Okay, thank you. Our next question. Regarding the forced air warmers, I believe I heard that these systems can be used with basic bed linens. Is this correct?
No. Okay. I assume what the question is referring to is taking a forced air blower hose and putting it under the sheets or covers on a bed or under the surgical drape. That's actually quite dangerous, because the temperature of the air that comes out of these warmers will cause burns. The reason they don't normally is that it's distributed within the cover, but the covers are carefully designed to distribute this heat properly. Just putting a forced air blower hose under surgical drapes will cause burns. Please don't do that.
I'd like to add to that. Once upon a time, a long time ago, we used to, in full transparency here, we used to try to warm the OR tables by doing that. And, we learned very early on that it's not best practice, and it certainly doesn't follow manufacturer guidelines. So if something were to happen, the institution has no leg to stand on. So please follow manufacturer guidelines and best practice.
Yeah, it's also unnecessary, and it doesn't actually help very much. Operating room tables are covered by 2 inches of foam. Sure, they feel cold when you first touch them, but the heat capacity of foam is negligible. Patients don't lose heat into the surgical table. It's less than 5% of the metabolic rate is lost into the table itself. So it's just not an important source of heat loss. Warming the table ahead of time might make patients feel good, but it doesn't actually change the heat balance. So it's just not necessary.
Yeah, and getting a warm blanket out of the cabinet is as effective and a lot safer.
Yes.
Next question is, what about ambient room temperatures? We have surgical physicians that want the rooms cold, and we're seeing more hypothermic patients in our orthopedic larger cases. What are practices you've seen that have best practice in the intra-op temperature regulation? Again, a great question. Dr. Sessler, would you like to take this one first?
Okay, we've studied this. So we did a 6-way trial of different ambient temperatures over the entire range of ambient temperatures that's used clinically, and with and without forced air warming. The results were that ambient temperature matters if you don't use forced air warming. It doesn't matter as much as you would think, but there are distinct differences as a function of ambient temperature. And it is true that you can keep any surgical patient warm by jacking up the ambient temperature enough. The trouble is you have to jack it up to a temperature that makes everyone miserable, as in pediatric operating rooms. If you use forced air, ambient temperature no longer has any effect on core temperature. Now, that might sound strange, but if you think about it for a second, what the patient sees is the forced air cover, not the ambient environment. And so the ambient environment temperature actually doesn't matter because that's not what the patient is seeing. So the answer to the question is you can set the room temperature to whatever makes the surgeons comfortable, and that's perfectly reasonable. They're professionals and they're doing a job, and their job requires a fair amount of work. Keeping them comfortable is perfectly reasonable. And you can keep your patient normothermic by using forced air.
And to add to that, our mantra is cover what you can. So if they're working on the left hip and they need that exposed, cover arms, cover head, cover chest, cover the dependent extremity, cover what you can.
That's a really important point. None of these modalities, from passive insulation to resistive heating to forced air, works by magic, of course. They only work on the skin surface that you cover. So absolutely cover as much as you can. And if you can't cover everything with forced air, cover it with passive insulation. Yeah.
In some of our larger orthopedic cases, we do frequently bring in 2 warming units, one for the upper, one for the lower. Again, yes, covering the dependent extremity whenever possible.
Yes, that's the strategy we used in Protect to get people to 37. Is we used 2 different warmers, and it's not trivial, but in fact, the average core temperature was 37.1 in a very large number of patients who participated in Protect.
And I've not studied this, but the other option is if you need to go up a little bit warmer in the room, do what you can to make sure that the surgeons are comfortable. We put ice packs on necks and things like that. They are covered. It's not comfortable.
I simply would use whatever room temperature personnel find comfortable.
Okay.
If you're actively warming your patient, ambient temperature just doesn't matter.
Okay, thank you. Next question, or as a follow-up, is best monitoring practice for these patients for consistency and the monitoring practice. I'm going to guess that they're asking about thermometry method. Is that monitoring has to happen? Again, we know that it's a critical vital sign. It's important for us to monitor our patients based upon all of our, various professional practice guidelines and our standards of practice. I'm thinking that maybe they're asking about modality, temperature modality in these patients, which are larger exposure cases.
Okay, well, patients need to have their temperature monitored, because if you don't monitor the temperature, you won't know what it is. And it's important and it's a vital sign. So do measure the temperature, measure it using the best available modality. Intraoperatively, that's usually esophageal or nasopharyngeal temperature. If those are not available, then use some reasonable alternative. Axillary temperature, measured carefully, is a reasonable alternative, for example. But you do need to monitor surgical patients.
Okay. And the clarification is the monitoring question was for the elderly that was found down. So
it applies to everyone. It's very simple. Everyone should be monitored. If you're talking about a preoperative patient where you can't use esophageal temperature, axillary is okay. Oral is actually remarkably good. So in a patient who can cooperate enough for you to get an oral temperature, that would be the best preoperative temperature. It's better than rectal temperature.
Okay, thank you for that. All right, we are going to be finishing up with our question and answer session. We all want to say thank you so much for joining us today. Dr. Schlessler, it's been a pleasure working with you today. Thank you to the audience for joining us. We hope that you've learned some really important take-home pieces of advice that you could implement in your workplaces. And we look forward to collaborating with you in the future. Thank you so much.
Absolutely. Thank you all.
Thank you.